Hi, my name is Julia Watanabe, and I am studying psychology at Universidade Federal de Mato Grosso do Sul. And I am currently making this video in regards to the evaluation process for the English extension course offered by my university. So the chosen article is about the implications of apathy and depression for everyday functioning in HIV/AIDS in Brazil. Well, the neuropsychiatrical correlates of HIV infection research are relatively unknown, but they have a large number of studies in North America and Europe compared to the smaller number in regards to other continents, especially southern countries, which includes Brazil. The lack of knowledge is concerning because North America and Europe's conclusions cannot be successfully applied to different cultures because the social-cultural context of HIV infections may vary across countries, which may impact the correlation between neuropsychological symptoms. Latin America ranks third among global regions affected by the HIV/AIDS epidemic, and Brazil currently has the largest number of infections, sadly. The majority of cases are due to heterosexual exposures, 32% to be specific, and it differs from the North America and Europe cases and results. However, their study had a big impact on ours due to their new concerning about the implications of apathy among HIV-positive people and stimulated actually research referring to the topic in Brazil. For example, the article I'm talking about. The research was conducted in a Brazilian hospital located in Curitiba, Paraná, and there were some limits in regards of the sample size. However, the results can be trustworthy in my vision. So the methods used in the study, in some cases, needed to be modified owing to the social context they were in. The researchers translated and changed the instruments of selection and the construction of neurobehavior assessments because they needed to fit the Brazilian subjects. There were 43 HIV positive and 29 HIV negative individuals. The control group, which includes the seronegative patients, could not have any neurocognitive morbidity unrelated to HIV illness, severe psychiatric disorder, heavy substance use within the past 6 months, medical confounds, education less than 4 years, and the inability to provide informed consent. Both of the groups underwent a lot of tests, including the Mini International Neuropsychiatric Interview Plus, known as Mini Plus, the Beck Depression Inventory 2, known as BDI-2, and a assessment of daily functional activities. The researchers wanted to correlate apathy with HIV plus patients. However, they did not want to inherently associate apathy with depression, so they had to modify and carefully analyze the results. So the results show that everyday functioning difficulties were apparent among the HIV positive group relative to HIV negative participants, which includes grocery shopping, managing finances, and housekeeping, which includes cleaning the house, that were the highest rates of dependence reported. The majority of HIV seronegative comparison subjects endorsed minimal apathy, only 3% compared to 37% in HIV-positive individuals. Seropositive patients endorsed a higher number of depressive symptoms on the BDI-2, and beyond that, 72% of them showed a life history of MDD, as we call the major depressive disorder, compared to only 14 of seronegative comparison subjects. In the end, the associations suggest that in the sample of Brazilian HIV-positive individuals, apathy and depression are indeed related, but not inherently related. So, in conclusion, depression and apathy affect HIV-positive people and produce negative results on their daily and cognitive functions. So that's it. Thank you so much for listening to me, and that's it.